Good morning, everyone. Welcome back. This is Periodontology, DH203. Today I'm going to start with talking to you a little bit about the basics of the periodontium. So Chapter 1 is called the periodontium. There are 4 tissues that make up the periodontium. You have your gingiva, your cementum, your periodontal ligament, and your alveolar bone. And if you look in your PowerPoints on slide 4, it shows you a picture of what each of these tissues look like and where they're located. It shows you a picture of healthy periodontium. So your healthy periodontium should have a sulcus depth of anywhere between 0 and 3 millimeters. The sulcus is the area that is between the tooth structure or enamel surface of the tooth and the free gingiva. It's the place where you put your periodontal probe. And it should be probing anywhere between 0 and 3 millimeters is considered healthy, along with no bleeding. The gingival fibers are intact that support the gingiva. The healthy alveolar bone or alveolar crest is approximately 2 millimeters apical to the CEJ. So something important to remember for down the road, that the alveolar crest does not sit right at the CEJ. It is about anywhere between 0 and 2 millimeters below the CEJ, or apical to the CEJ, I guess I should say. The 4 tissues that make up the periodontium are the gingiva, cementum, PDL, and alveolar bone. So let's start with looking at each of these tissues separately and discussing some of the features of each of them. We're going to start with the gingiva. So the first thing we want to talk about with the gingiva is that it's the part of the mucosa that surrounds the cervical portions of the teeth and covers the alveolar process. So the gingiva contains different types of gingiva. They cover the cervical portion. They're located coronal or coronal to the CEJ. In other words, they cover the part of the enamel surface of the tooth. So your gingival margin should actually come up just slightly up onto the enamel surfaces of the tooth. The outer surface is epithelium, and then the underneath or underlying surface is connective tissue. That function is to protect. It protects the underlying structures. It extends from the gingival margin to the alveolar mucosa. So you have your gingival margin, or the very top part of your gingiva, all the way down to your alveolar mucosa, or that softer area when you pull out your lip and it kind of softens into the vestibule. So the boundaries of it are at the most coronal part, or closest to the tooth surface, is called the gingival margin. And that's the very top upper boundary or upper edge, and the lower or the most apical, think of the apex of the root or closest to the apex of the root, because on the top it's going to be, or in the maxilla it's going to be up, is the alveolar mucosa, which is dark and red and kind of softer or stretchier. Then you have your free gingiva. So your free gingiva is going to be that area, that cuff around the tooth that is not attached to the tooth surface. So the free gingiva is actually the outer part of the gingival sulcus. So when you are using your probe and you're putting your probe in between the tooth and the free gingiva. So if you were to picture it like a turtleneck, your free gingiva would be like the collar of a turtleneck. So it would be the part that's not attached. So picture yourself as wearing a turtleneck, and the part that pulls away from your neck is the free gingiva. The very top part being the gingival margin. The gingival margin is follows the contour of the teeth. So basically it's usually referred to as being scalloped. So the gingival margin kind of follows, it's what gives those nice little arches around your teeth. It's scalloped in shape. It's the lateral wall of the sulcus. So here we are with our medial and lateral terms again. So the lateral wall of the sulcus would be the furthest away wall. So it would be the lateral wall. The medial wall of the sulcus would be the tooth surface, or closer to the midline. So if you were to take that collar and stretch it away, the lateral wall would be right here on your free gingiva. The medial would be against the tooth surface. As we transition from the free gingiva to the attached gingiva, there's a little groove along the area that corresponds with the depth of the sulcus in health. So in other words, if you are sticking your probe in to the sulcus and you're going down 3 millimeters before you hit the contact, right on the outside of the free gingiva, corresponding with that sulcus depth in health, would be something called the free gingival groove. And it's actually like a separation between the free and the attached gingiva. Usually you can't see it. Occasionally on certain areas of the mouth you might be able to see it, but I wouldn't count on being able to see it, but you can sometimes. The attached gingiva is next, and that's the tissue that's firmly attached to the underlying teeth, cementum of the teeth, and the periosteum of the alveolar bone. So the attached gingiva is firm. It's usually light pink in color when it's healthy, but it's very firm, and it can have something called stippling on it. The distinguished difference between the attached gingiva and the free gingiva is only detectable on the facial surfaces. So if you pull out your lip and you look at your gingiva, pull out your upper lip and look at your gingiva, you will be able to see you have your free gingiva and your attached gingiva. But if you go on the palatal surfaces or on the lingual surfaces, there's no definite distinction between the two as far as their appearance. So we usually, when we reference the free gingiva and the attached gingiva, we're looking at it from the facial surface. In health, the attached gingiva may have that orange peeling appearance or something called stippling that I mentioned a little while ago. So it has just kind of a matted look, like matte as in it's not shiny, it's got the little grooves or indentations in it. On slide 23, there's a real good picture of stippling. So when you are going through your slides, make sure you take a look at that. So below the attached gingiva then, that separates the attached gingiva from the alveolar mucosa is the mucogingival junction. The mucogingival junction usually can be seen, although not always. So if you were to take your lower lip and pull it down away, you should be able to see a definite demarcation or kind of a scalloped line that separates that attached gingiva from the soft alveolar mucosa. The attached gingiva also includes the interdental gingiva or interdental papilla, which fill the embrasure spaces and prevent food from getting stuck between your teeth. Your attached gingiva, also one of the purposes of your attached gingiva is to help keep that free gingiva, it protects the free gingiva from mastication or occlusal forces so that it doesn't continue to pull away from the teeth. So it's very firmly attached so that it doesn't pull away from the teeth very easily. On your interdental gingiva, you have a facial surface and a lingual surface and a depression in between called the caul. So the caul is only present though when teeth are in contact. So in other words, teeth have to be touching each other like this in order for there to be that caul. If teeth are not in contact with each other and they are separated, the interdental papilla will usually become flat or blunted and the caul is not present. The sulcus, the space between the free gingiva and the tooth, measures 1 to 3 millimeters in health. The base of the sulcus is the junctional epithelium, and we're going to talk about that in just a few minutes here. The periodontal ligament. The periodontal ligament is dense fibrous tissue that attaches the tooth from the cementum to the bone. So it takes the root of the tooth and the root is covered with cementum, and it connects that cementum to the alveolar bone. The functions of the periodontal ligament are to support the tooth in its socket. So your root of your tooth does not sit directly against your bone. And you've probably already heard that because we've referenced the periodontal ligaments before, but also in radiography. You probably have looked at that periodontal ligament space around the tooth. So the ligaments are soft and fibrous, so you don't actually see the ligaments in a radiograph. But you would see the space between the root and the alveolar bone. And in that space are a bunch of fibers that run back and forth, and they support the tooth in the socket. They are also what provides the sense of pressure and pain on a tooth. So if you were to, say, eat like a bagel or French bread and you torque the tooth to the side, so you bite into it and you pull like this with the bagel or the French bread, and you torque the teeth, you can stretch those ligaments and they will feel that pressure or pain. They provide nutrients to the cementum in the bone, and they provide cementoblasts and osteoblasts. And if you remember from your basic like anatomy stuff, blasts help to build cells. So they do provide cementoblasts, which help build cementum, and osteoblasts, which help build bone or alveolar bone. And they help to remodel the alveolar bone or keep it shaped. Then we have the cementum. The cementum is mineralized connective tissue that covers the roots of the teeth. It's softer than dentin and enamel. So the cementum is more prone to caries. And we discussed a little bit in dental anatomy about caries and how if you have gingival recession and so the root of the tooth is exposed, and a patient, which you see a lot in patients that have periodontitis, they've got recession, and so the roots are exposed, and that exposed cementum is not as hard or as easily protected as enamel is from tooth decay and tooth bacteria. And so patients that have recession are more prone to class 5 caries, or caries on that cervical area of the tooth where the root is located. And so we want to keep those areas more mineralized through fluoride and things like that. So the cementum also contains Sharpie's fibers. Those are the terminal ends of the periodontal ligament fibers. So as the periodontal ligament fibers course through that periodontal ligament space, they have these little ends on them, kind of like brushes or bristles, that will attach them one side to the cementum and the other side to the alveolar bone. And that transitions us to the alveolar bone. So the alveolar bone is mineralized connective tissue as well, and its presence is dependent on the presence of teeth. So it basically goes by the philosophy of use it or lose it. If you do not have teeth, and so therefore there's no occlusal pressure, no occlusal force on the alveolar bone, it doesn't continue to regenerate or remodel itself, and therefore you lose that alveolar bone over time. So sometimes patients that are edentulous, you'll see like how their lips and cheek area sink in because they no longer have the teeth or the nice alveolar ridges. That has an effect on patients and their ability to have restorative options. So if a patient loses teeth in an area or in an arch, and they lose that alveolar ridge or that alveolar bone starts to narrow, it lessens their ability to have things like implants down the road. Or cosmetically, it makes a bridge a little bit not as nice looking or not as functional. So the loss of the alveolar bone makes a big difference. The alveolar bone houses the roots of the teeth. And through that periodontal ligament and the stimulation of the pressure from mastication is what keeps the alveolar bone regenerating. So you have different layers of your alveolar bone. You have your alveolar bone proper, which is the thin lining layer of the socket and has the Sharpie's fibers embedded in it. So if you look at a radiograph, you can see kind of a little white line that lines the sockets of a tooth, especially if a tooth has been extracted, and you can still see that alveolar bone proper, or that thin lining that outlines it. Then you have your cortical bone. Cortical bone is very dense. It's on the buccal and the lingual walls of the socket. So the outer and the inner are the cortical walls, or cortical plates as we call them. I don't know if you remember from dental anatomy, but a plate is like a flat bone, a dense flat bone. So we call them cortical plates. They form on the buccal and the lingual. And in between those cortical plates, you have something called cancellous bone. Cancellous bone is kind of spider webby looking. When you look at radiographs, sometimes you can see like that spider webby appearance. It's not as dense. You have more cancellous bone on your maxilla than you do on your mandible. And so therefore, as far as bone loss and bone density, you have more density on your mandible. And then you have your periosteum, which is the outer surface of the bone. It's like a thin covering over the outer surface of the bone. Also covered in this chapter are, toward the end of the chapter, we talk about the nerve supply and the blood supply to the periodontium. Most of that's going to be review. Remember that the cranial nerve 5, or the trigeminal nerve, provides both sensory and motor innervation. So there's pictures on slide 54 and 55, 54, 55, and 56 that show you basically, but the nerve innervation to the periodontal ligament and the teeth of the maxilla is through the superior alveolar nerve. So you have your posterior superior, your middle superior, and your anterior superior alveolar nerves. And your innervation of your teeth and periodontal ligament on the mandible is going to be via the inferior alveolar nerve and the branches that come off of it. Again, there's some good pictures that show you the nerve innervation and nerve supply to the teeth. And then you have your blood supply. Your blood supply is how your teeth and the ligaments and the supporting structures get their oxygen and nutrients to the cells. So the vessels of the periodontium supply blood to the periodontal tissues. They have supply to the maxilla and mandible. The major function is to transport oxygen, nutrients, and then they remove CO2 or carbon dioxide and waste products from the cells to keep them alive and healthy. The maxillary gingiva, periodontal ligaments, and bone are supplied by the anterior and posterior superior alveolar arteries, infraorbital and greater palatine arteries. And the mandibular gingiva, periodontal ligaments, and bone are supplied via the infraorbital arteries and the branches of the infraorbital arteries. And again, there are some nice pictures that show the different blood supplies and how they get to and from the teeth. So please take a look at those pictures. And then lymphatic drainage. We know that lymph nodes are little bean-shaped tissue that filter. Their job is filtration. They filter out bacteria, viruses, fungus, anything that's not supposed to be inside the cells. They're located all over the body. And just for review, the lower mandibular incisors and periodontal ligament and supporting tissues drain to the submental lymph nodes. All the rest of the teeth and supporting structures drain to the submandibular lymph nodes. The submental drain back to the submandibular, and then from there they all drain back to the deep cervical lymph nodes. The maxillary third molars will drain directly back. They don't go to the submandibular. They go directly back. They actually go to the jugulo-digastric lymph nodes. There's a nice little slide 65 that shows you that breakdown, and 66 has a nice picture so that you can kind of refresh your memory of all the breakdowns of those. We're going to continue to elaborate and talk more about all of these different parts of the periodontium as we go through future chapters, but please bring your questions with you to class and we'll discuss this further.